Okay, so for those of you who don't know me, my name is James Calvert and I'm a respiratory consultant at Southmead. And I've just realised I have strange ghostly eyes, so there we go. First of all, I want to just reassure you that none of us know what we're doing with coronavirus at the moment, and we're all feeling our way. So the presentation I'm about to give is based partly on my own clinical experience working with COVID patients for the last sort of 3 or 4 weeks, and partly experience how rapidly things are moving on. So first of all, just a quick bit about coronaviruses. So every single person on this call will have had coronavirus. So between 10 and 30% of upper respiratory tract infections, so coughs and colds, are caused by coronavirus. But in the last couple of years, with environmental change and what have you, we've had 3 serious coronaviruses come to light. So there's SARS and MERS. MERS is the most recent one prior to COVID. That's Middle Eastern respiratory syndrome. And a friend of mine who works in the Middle East said that it caused a huge amount of fear and concern, much as COVID has now. But for whatever reason, SARS and MERS didn't achieve the sustained transmission that COVID has. It came to light, first of all, as we all know, in Wuhan at some point in December. And I actually went to Wuhan when I was 19, and I visited the wet animal market that the virus is supposed to have started in, and I can honestly say it was revolting. Kittens, puppies, snakes, bats, anything with a pulse was basically there available to be eaten. So if you were ever going to have animal to human transmission, Wuhan was the place for it. And I think most of us are probably aware that the very prominent symptoms are fever and cough, but we'll go into that in a bit more detail. And we all know that some people get very sick and unfortunately land up in hospital. So this is a picture of the virus. The picture on the left-hand side of the 2 viral particles, you'll just see that there looks like a sort of a light arrangement of dots around the viral particle. Well, that is the corona, those dots. And the coronavirus was discovered by a female scientist, I think called Dr. Johnson in the 1950s. And suddenly her name is being remembered as the person who took the first photograph of the virus. So initially, the virus was thought to have spread from bats either directly into humans or via an intermediate animal, possibly pangolins, which are another tasty snack available in the market. But very rapidly, it became apparent that human-to-human transmission of the virus was possible. And I think all of us have been fairly amazed by how rapidly the virus has spread. And I just wanted to share this video with you because I think it's really emblematic of what it is we're dealing with. So for those of you who don't know, this beach here is Fort Lauderdale in Florida. And every year at spring break, which has just passed, college students from all over the United States all come together to read poetry and drink soft drinks, as you can imagine. Now, they were advised not to come and they widely disregarded it, and this is the impact of it.
We wanted to see the true footprint social gatherings like spring break beach crowds could really have on our society in the face of a global pandemic. To do so, we started with the big picture, powering our engine with billions of anonymized location data points from mobile devices across the globe. Using tectonics, we can then zoom in on specific regions. Here, we focus specifically on just one beach in Fort Lauderdale during the month of March. Again, each of these data points shown on the map corresponds to a unique mobile device active on a given day. You can see clearly that device activity spikes during the 2-week stretch of early to mid-March corresponding with spring break. No surprise. Now, using an analysis called a spider query, we can actually track movement of these devices over the remaining weeks of March, seeing where these devices went after spring breakers left the beach. As we zoom further and further out, it becomes clear just how massive the potential impact just one single beach gathering can have in spreading this virus across our nation. It can be hard for us to realize sometimes just how connected our world really is. until the data tells the stories that we just can't see.
So I'm sure you'll all agree that that's pretty scary. And I think it really sort of sums up the challenge that we've all got and why we've got to be so careful with self-isolation, because as we could see from that video, that crowd that we can actually see in front of us dispersed over the whole of the northeastern United States, and each person with COVID on average infects 3 or 4 other people, and that's how you get this exponential growth. So in terms of the pathology, the virus is acquired through inhalation, and the viruses replicate in the lower respiratory tract. And you can see in the diagram on the right-hand side here that essentially inflammation leads to fluid accumulation within the peripheral airways, and it's that impairs gas exchange. And you know, I've been a chest physician for a long time, and this virus does not behave in a way that I recognize. People can be extremely respiratorily impaired, but actually not without that much in the way of febrile infection type symptoms. And it's quite deceptive that way. So the only way you can really get your eye in is by seeing a number of patients. But once you've seen a few, you'll realize that they look different from the patients you're used to looking after. You can be quite unwell without looking as ill as you might expect. So the incubation period is thought to be about 5 days, and it seems to be up to about 10 to 12 days. And the vast majority of people have a fever. In some studies it's 98%, in other studies it's only a half. So just because people don't have a fever, don't be put off thinking this can't be COVID. And then a dry cough seems to be the other sort of cardinal feature. And then all of these other symptoms, myalgia, fatigue, headache, vomiting and diarrhea, loss of smell, loss of taste. These are all things that we've really just become aware of in the last sort of 2 or 3 weeks or so. So, you know, we're all learning all the time. And I was having a discussion with some GPs yesterday who think they've begun to see people with viral looking rashes and arthralgia, so sort of painful joints and things. And I think the take-home message really is that anything you've ever experienced in the context of a viral infection can occur with COVID, but there do seem to be 1 or 2 sort of slight differences, particularly in the way COVID interacts with respiratory disease and asthma in particular, and I will mention that later on. So in terms of the sort of distribution of people, there's 900,000 people in Bristol. And until social isolation was introduced, the modelling suggested that 700,000 of the 900,000 population in Bristol would be infected in the next 4 months. And had that occurred, they were anticipating that about 30,000 people would need hospitalisation in the next 4 months, and 3,000 to 4,000 people would need ventilation on intensive care. Now, I'm very pleased to say that, you know, everything I've seen at the moment suggests to me that in Bristol anyway, and in most of the NSSG, social lockdown has dramatically changed what we're thinking. We're not overwhelmed in the hospital at the moment. It is all under control. And, you know, there's even talk that there's a possibility that the Nightingale Hospital may not be used. And if it's not used, fantastic. So 80% have mild disease or asymptomatic disease, 15% have severe disease, meaning that they may need treatment with oxygen therapy, and about 5% of people need intensive care. Unfortunately, by the time you make it to intensive care, the death rate's somewhere between 50 and 70%. So, you know, we've all seen Boris go to intensive care and survive, but he had about 1 in 3 chance of not surviving. So I've got this graph here, which gives us the natural history of the disease. So the top bars are survivors and the lower bar are non-survivors. And you can see that the real clinch time seems to be around, the first clinch time comes about a week. So that's when your fever and cough can turn into something more serious. Now, that doesn't necessarily mean you're not going to recover. So that's probably the first thing to reassure people about, that you're going to have a fever and cough, and there is a chance that you're going to start getting worse about a week in. Okay, and that's not what people will be used to. People are normally used to getting better about a week in. And then the key thing is this sort of period around day 10 to 12. And that's when we're seeing people really deteriorate. And you can see on the lower graph for the non-survivors that people on average in this study from the Lancet were going to intensive care round about day 10 or 11 and being ventilated about day 14 or 15. And generally, you know the way things are going to go by about day 21. And that does seem to be reflective of what we have been seeing. And then you'll see down, you'll see down here that there's also this issue of acute cardiac injury, acute kidney injury, and secondary infection. And that seems to be really important. Now, bear in mind that this is very old research because it's almost 4 weeks old now. And I think one thing that we're really seeing is far more in the way of venous thromboembolism than we expected. So once you tip out of the first phase of the illness into the second phase, you do seem to get microemboli. And I've seen pleuritic chest pain just with COVID, and I've seen pleuritic chest pain because it's indicative of a PE in COVID. And microemboli also seem to be occurring, and they can lead to cardiac injury, respiratory injury, and renal injury, but they don't necessarily show up on imaging. And I'll talk a little bit more about that later on. So this is just an infographic from the World Health Organization, and the bar on the left-hand side showing mild, moderate, severe and critical shows the sort of general spread of severity of the condition. And you can see that even critically ill people do get better and recover, but unfortunately, as we know, a cohort of people can progress and lose their lives from the infection. And I think one of the things that's really important when we're thinking about how we use our healthcare resources is the likelihood of people making a recovery. And this is a conversation that we're having to have with a lot of patients, unfortunately. So first of all, if you look at death rates by age, you can see that for the general population in the over 80s, the COVID death rate is about 15%. And you'll also see that the death rate in very young people is very, very low, but it's not zero. And unfortunately, I think we've had a couple of children under the age of 10 who have passed away in the UK in the last few weeks. But for the most part, the kids who've really been hit badly are kids who've had chronic underlying conditions. In terms of important comorbidities, cardiovascular disease, hypertension and diabetes seem to be the really big issues, and then the range of chronic lung disease. So COPD, interstitial lung disease, bronchiectasis, but surprisingly a lot less so asthma, and that is something I'll talk about later on. Now, one of the other things that's odd about COVID is that when I'm looking after people with normal chest infections, in inverted commas, you usually get a pretty good idea of whether things are going to go badly or not. But my impression so far is you can't really stand at the bottom of the bed and know who to worry about with COVID. So you really just have to go with symptoms, signs, and what they're telling you. So my practice now is anyone with those comorbidities of age, cardiovascular disease, diabetes, in my head, they're in a high-risk group. And there are blood tests that raise my level of anxiety, if you like, and they are reduced lymphocytes, especially when compared with neutrophils. And that's a feature of viral infections generally, and a very high D-dimer. So for the people who become very unwell in hospital, once the D-dimer goes over 2,500, we're beginning to therapeutically anticoagulate these people. Raised troponin can occur in sepsis, but we're also wondering whether it's a feature of microembolism in the heart. But I would have thought in the community that these probably aren't things you're going to see, just so you know, there's basically two phases to COVID. The first phase is the viremic phase, and that's when the virus is replicating in your airways. That's when you get the cough, that's when you get the fever. And people are often not that unwell at that phase. And some people never become unwell, and they mount an effective immune response and get better. Where people seem to get very ill about 7 to 10 days in is when they basically get something called a cytokine storm. They get overwhelming activation of the immune system. And the immune system then triggers the clotting cascade and all of these sort of features of the deterioration that we've grown to recognise. It seems to be a lot commoner in men, the sort of severe deterioration. Something like, I think, 80% of the patients in ITU are male, and it was already known, unfortunately, that men don't mount such an effective immune response against viral challenges. So another example why I'm being removed from the gene pool by evolution, I'm sure. Now, I just want to talk about triage now, and this is where it's beginning to get very clinical. So these are the triage criteria for hospital, okay? So we've got mild patients, moderate, severe, and critical. Now I want to focus first of all on the mild patients. So the mild patients are people with oxygen saturations of over 94% on room air and a respiratory rate of less than 20. Now, if these people get referred up to hospital, they will almost certainly be sent home. Now, we're being quite lenient at the moment because we were worried that the hospital would be full, and it isn't. But we will really be looking at admission only if the SATs are less than 94%, unless there are other sort of social factors and things. And our aim is to maintain SATs around about 88 to 94% on 10 to 15 litres of oxygen. Predominantly we're focusing on using nasal cannulae and then moving to a non-rebreathe mask. And to keep things simple, we're trying not to give oxygen via any other modality. People who are severe are essentially the people who can't maintain their SAPs on straightforward face mask oxygen. And in those patients, we're using CPAP, but we're not using non-invasive ventilation very often, except perhaps in a patient with COPD, where we might use bi-level non-invasive ventilation. So it's really paracetamol and fluids at step 1, oxygen via nasal cannulae or a rebreathe bag, non-rebreathe bag, phase 2, and then phase 3 is either CPAP or intensive care, or we might begin to think about palliating the patient depending on the escalation. Okay, and critical is obviously when people need organ support. Now, this is a screenshot from the community triage guideline, and if you look at the bottom of the screen at the more unwell category here in yellow, you'll see this is the group with SATs of less than 94%. So these are the patients who were interested in seeing in hospital is okay for managing the patient at home. The mild to moderate patients we're hoping will be kept at home at the moment. So if you are more unwell, the community guidelines suggest these may be the patients that need a face-to-face assessment or consideration of referral to hospital. And the people who are critically unwell clearly need referring to hospital, and that's these patients who are clammy and sweaty with overt signs of infection. And actually something I didn't mention earlier was confusion. And a lot of the more elderly, frail patients we're seeing presenting with COVID are presenting with a degree of confusion. And it does seem to some extent to be a direct effect of the virus rather than because they're septic. If you use Connecting Care, the Charlson Comorbidity Index is now in the kind of tiled dashboard on the front screen for every patient. And it's been agreed across BNSSG that the triage tool that will be used when you're making a multidisciplinary assessment of a patient is this thing, the Charlson Index. And if you're not familiar with it, I've put a table on the right-hand side of the screen that basically shows the number of points you get for underlying diagnoses. So you can see down towards the bottom that if you've got diabetes or kidney disease, or you've had a tumour, you get 2 points. If you've got serious liver disease, you get 3 points. And then if you look across to what that means in terms of mortality generally, if you're admitted to hospital, for instance, with a Charlson score of 6, your risk of dying is 24% in hospital, and your risk of dying would be 98% within the next 10 years. And that's pretty well validated, but as you'll see from the text above, and this is taken from the BNSSG community guideline, the Charlson Index underestimates mortality in COVID. And unfortunately, about 50 to 60% of 80-year-olds admitted to hospital with COVID are dying, unfortunately. I've sent through the BNSSG community guideline, and this is the one-page summary on the first page. I'm not going to go through it in detail, but some of the questions I got were about how you should be assessing patients in the community, and it's all there, chapter and verse, in this document that I've shared with you. And just to emphasise, your main assessment of the patient will be clinical, and it can be over the phone. How breathless are you? What are you able to manage around the house? Are you eating and drinking? Can you manage the stairs? And actually, it's in the minority of patients where you'll need to measure SAPS and blood pressure and things. And one thing I would say is that listening to someone's chest with COVID with a stethoscope is actually pretty unhelpful. Most of the patients, even those with bad COVID, have got a normal sounding chest. So the rare occasions now when I'm listening to the chest, I'm listening to the chest to try and work out the differential diagnosis. So again, this is a screenshot from the BNSSG clinical guideline, which gives symptoms and signs to help you identify patients who are deteriorating. And none of them are COVID specific. So severe shortness of breath at rest, difficulty breathing, talking in short sentences, blue lips, feeling cold and clammy, collapse, lightheadedness, confusion, not weeing as much, but also coughing up blood. So had you asked me a month ago, I would have said no hemoptysis with COVID, but I was out of date a month ago. And that's just a sign of how much things are changing. Now, the only thing I would say, particularly around the severe shortness of breath thing, is that everybody who I've seen with an infection in the last 3 or 4 weeks is terrified. And we've had a couple of people admitted to hospital with COVID, but hyperventilating, not because of the COVID, just because they were so scared. And that's something you need to bear in mind when deciding who you need to assess, because it might be that what you're needing to do is having a video face-to-face consultation, perhaps with someone, to talk them down and try and get a sense of whether this is true physiological deterioration or whether it's anxiety. And then this is the final thing that I thought might be helpful for you. And again, screenshot from the local guideline. It's when to use antibiotics. So in our triage, community triage breakdown, for patients with normal SAPS, i.e. over 94%, where you think they've just got COVID, you don't need to give them antibiotics, okay? You only need to give antibiotics to the more severe patients and in the patients where you're concerned that there may be a bacterial infection. And you'll see in the right-hand side here, the symptoms that make a bacterial cause more likely are people who've been perhaps ill for a while and then have rapidly deteriorated. Now, that does occur in COVID, but the severe patients, pretty much all of them in the hospital, we're putting on antibiotics because it's actually very difficult to tell whether they've got a bacterial infection or not. I would say pleuritic pain, which is on this list, doesn't actually help you differentiate. Purulent sputum does, so people with COVID don't normally cough up mucky spit. So if they are, they've probably got a bacterial infection. And then It mentions high fevers and things, but again, that's not helpful really in my experience in differentiating bacterial from viral infection. In terms of antibiotic choices, what you normally use, so doxycycline, 200 milligrams on the first day, 100 milligrams thereafter, with a total duration, of course, of 5 days. Alternatively, amoxicillin if patients are pregnant or breastfeeding, for instance, or allergic to doxycycline. You can use macrolides, but bear in mind with macrolides, you just need to keep in mind the possibility of cardiac side effects like long QT syndrome, and that's perhaps more important than normal here, given that we know that COVID can have cardiac side effects. But as always, if you're not sure, ask a microbiologist or use one of the helplines that have been set up. So you've got the Bristock coordinator, you've got the respiratory community hub being hosted by Sirona and staffed by the community specialist respiratory nurses who are extremely experienced and will be able to answer very many of your questions. There's the Ask MedReg phone line, which is for the community as well if you've got medical questions. And there's going to be a community sort of virtual ward round with secondary care respiratory physicians at UHB and NBT occurring, I think, on a daily basis, but that's just been clarified at the moment. So things to look out for: increasing breathlessness, or if they're on oxygen, increasing oxygen requirement, pulse rate going up, urine output falling, all the things that you would expect, and particularly altered mental state. And I think, you know, if someone's got an altered mental state, you need to be sending them into hospital. I've mentioned things like rising D-dimer, rising CRP, falling lymphocytes, but these are the things we're using in the hospital, and all of the community guidelines, which I agree with, stress that your assessment should be mainly a clinical one, symptoms, signs, and the patient's history. So this is really just for interest as much as anything else. This is what we look for when people come into the hospital. Now, in China, they use CT scanning quite early on in the patient course. That is not something we're doing, but it may be of interest to you to know that a month ago, so before the whole world fell apart, a month ago in our lung cancer MDT, when we were looking at CT scans of people who were being considered for treatment with lung cancer, several of those patients had very typical changes of COVID on their CT scans, but were completely asymptomatic. So we've really got no idea of how wide COVID has spread in the community, but I suspect there are far more people who have been infected than we're actually aware of. So this is a chest X-ray in someone who's got COVID really bad. And for those of you not used to looking at chest X-rays, you've got the kind of heart in the middle here, but you can't actually see any normal lungs. So this kind of ground glass white interstitial change is the change that we're seeing with severe COVID. And you can tell by the number of lines on this patient's chest that they're in intensive care, and that's the endotracheal tube there. So these patients need help recruiting uninfected alveoli and shifting fluid out the lungs, and that's essentially what they're being offered on intensive care. This is much more typical. This is a CT scan, and you can see these puffs of ground glass that tend to be peripheral and quite localized and multilobar. And this is someone who would be moderately unwell. This is perhaps more typical. So you've got one little area here, and you've got two areas posteriorly. And the first 2 or 3 patients I saw with COVID had CT scans that looked like this, but chest X-rays that were almost completely normal. This is actually a patient I saw, and you could just see this, but it really wasn't very prominent. So radiology can be helpful, but an awful lot of people have got normal chest X-rays. And here's another reconstruction of a CT that just shows this peripheral shadowing. And then just to reiterate what I said right at the beginning, if you listen to this patient's chest, the chances are it would sound completely normal. There'd be no crackles, no wheeze, and you'd be hearing normal vesicular breath sounds. So in fact, I'm using my stethoscope far less than usual because it exposes you to the risk of infection, and very rarely does it add additional information. This CT scan, however, would cause us problems. So these changes here, this is called honeycombing. So this is a patient with interstitial lung disease or possibly emphysema, and then they've got a background of ground glass. That can occur with interstitial lung disease, can occur with pneumonia, and it can occur with COVID. So this would be reported as intermediate risk of COVID. So at the moment, we don't have an antibody test for COVID. So we can't take blood tests from people and say, you've had it and you're immune. It is possible that we won't develop immunity. If you think about it, we catch a cold every year, and quite often that will be coronavirus. And they've been trying to find a vaccine against the common cold for nearly 60 years now without success. Now, the amount of money and expertise being poured into a search for the COVID vaccine, we can only hope they're successful. But there was a paper published this morning, in fact, from the epidemiology group in China, who have identified 15 different strains already of COVID in their population. And to give you an example, one of the strains has only been identified in one other person in Australia. In the western part of the United States, in Washington state, there's a strain that seems to be relatively less pathogenic circulating. Unfortunately, the most pathogenic strain, the one that makes people most unwell, is the one that's circulating in Europe and in places like New York. But what we don't know yet is whether there are different strains circulating within Europe, which is why Italy, for instance, may have been hit so terribly hard, but other areas like Germany less so. We're not sure if that's the virus or the way in which they handle the infection. So at the moment, all we can do is tell if you've got the virus at the moment, and that's with a nose swab. And one of the things that really isn't being talked about is it's really not a very good test. So even if the swab's done really well, and you have to really scrub at the back of the throat because you're trying to get cells to do the test on, you're going to miss 1 in 5 cases. So I'm seeing a lot of patients who I am certain have COVID, but who have negative PCR tests. So just keep that in mind. If you think it's COVID, but the test's negative, don't be put off. We do other tests, and that's really to help us try and work out whether this is what stage we are in the COVID infection. There's one thing here mentioned, procalcitonin, which we're not using routinely at the moment, but we think we might start using. Procalcitonin tends to be elevated in bacterial pneumonia, but isn't elevated in viral pneumonia. But the other things I've already mentioned. One of the things that we need to think about in hospital, and it's the first thing we do during a primary assessment on admission, and it's the thing you need to be thinking about with all the patients you're seeing in the community, is what level of care is appropriate for this patient. And that should be based on a holistic review of the patient, but including the Charlson Index, and just thinking what will transfer to hospital provide in terms of benefit for this patient. Because unfortunately, if someone who's going to die anyway is sent into hospital, then they may end up dying without their family around them in the hospital. We're doing our best to be flexible around that, but there is very little visiting because of the risk of cross infection. And I don't know about you, but if I'm not going to recover, I'd rather be in my own bed than in hospital. So quite a somber thing to think about, and it's something that needs to be done in partnership, in discussion with the patient and with their families. And just remember that there are always people you can ask for help and advice, and your first level of support should really be the GP, and they are backed up by people like the Bristock coordinating doctors. So there are senior experienced GPs who are there for advice, and will be GPs working with the BNSSG Sirona Community Hub who can help you with these difficult decisions. Nobody should be making difficult decisions in the community that they're uncomfortable with on their own. And even in the hospital, we're buddying up with other consultants to make these difficult decisions. They're difficult for everyone. Now, this slide here just reminds us that there's lots of ways of delivering oxygen. Okay, but really in the hospital, we've narrowed down to nasal cannulae and non-rebreathe masks. High flow oxygen or airvo is something we're not using because it's an aerosol generating procedure. We are using CPAP and we are using ventilation, but obviously those are hospital-based things. So the commonest complication is something that looks a bit like acute respiratory distress syndrome, so shock lung. And that's what I showed you on that chest x-ray of the patient on intensive care. Now, it's not like normal ARDS in that they don't quite respond in the same way when they're ventilated, but we'll no doubt learn more about that in the coming weeks. People also get hospital-acquired pneumonia and sepsis, just as they would at any other time, but you need to keep in mind cardiac injury and venous thromboembolism. And we're being very, very careful with fluid management. It was initially thought that we needed to be quite conservative with fluids, or we would run the risk of harming people. And in fact, that's eased back a bit because it looks as though people were getting kidney injury because we were being too mingy with the fluids. So again, something we've learned in the last 3 or 4 weeks. Southmead was the second hospital in the country to get up and running with clinical trials. We've been running clinical trials for COVID now for almost a month, and we've recruited over 100 patients, and there are trials coming on stream all the time. And what we're trialing at the moment is low-dose steroids, lopinavir, ritonavir, hydroxychloroquine, much beloved of Donald Trump, and we were hoping to use remdesivir, but that's not going ahead in Southmead, but it is in other hospitals in the UK. But just so you're aware, papers published in the last 2 days suggest that hydroxychloroquine and lopinavir, ritonavir appear to have no benefits. So we were right to use them in clinical trials and not to willy-nilly put everybody on them. The trials that have been published aren't great and they've not been peer-reviewed, but healthy skepticism is the way forwards. This is a screenshot from the Community Palliative Care Guideline, just emphasising that everybody with COVID who's febrile should be on paracetamol, and if people are needing PRN medications for symptom relief, think about introducing something regular, and for most people that will be morphine sulfate, MR, 10 milligrams BD, or 5 milligrams BD if it's someone who's small and frail, and lorazepam. So morphine for breathlessness, lorazepam for anxiety. Okay. So in summary, COVID's a mild illness in the majority of people, the vast majority of people, but up to 20%, 1 in 5, need to be admitted to hospital, and up to 5% need to go to critical care. These proportions may fall as we understand what proportion of people in the community have had asymptomatic infection. You need to remember to triage people and always think about what level of escalation is most appropriate. IV fluids clearly aren't relevant in the community. Keep using PPE. Now, PPE for the majority of patients are surgical gloves, an apron, and a surgical mask. We're only using gowns and we're only using PPF3 masks if we do things that are aerosol generating. But taking a swab from the back of someone's throat is aerosol generating if they cough on you. So just keep that in mind. And remember to wash your hands and wash them again. And by now my hands are falling apart. So if yours aren't, you're not washing your hands often enough. Now I'm going to stop at that point. I have cut and pasted the questions that some of you sent me, but I just want to give you the opportunity of firing out some questions just now, and I'll answer the questions that I've got on the screen, and I'll think about how I answer the questions as you fire them at me.
Hello, it's Claire. Thanks, that's a really helpful summary. I just was scanning the questions on the list, and I think, like you say, that where we know the answers, the sort of the questions that you've covered, the sort of the key points, and I think what we're thinking about in the community is kind of, is there anything we can do to facilitate recovery without putting patients at risk, and particularly thinking about those cardiac risk factors. And actually, we know that for people who've had a period of sustained inactivity, who've been very unwell, that graded activity is what they need. It's just being mindful, thinking about the cardiovascular comorbidity risk factors. We know that the trials about early pulmonary rehab have had mixed results in the past. What would your advice be around that kind of that thinking?
Yeah, so that's a really, really good question. Not an easy one to answer, which is why it's good. So we're all over the cardiac side of things in hospital. We're checking troponins, we're doing ECGs regularly. So if we're concerned that someone's had a sort of subclinical infarct, it should be in the discharge summary. Okay, so I would pay attention to people's pre-existing cardiac risk factors, but I probably wouldn't worry that someone's had a prognostically significant cardiac event in hospital without us knowing, because there are lots of staff and not so many patients. We have 200 empty beds.
Yeah,
perspective. And I absolutely agree. You need to get these people moving.
Lovely.
Okay. So gentle graded exercise.
Lovely. And my other question is thinking about the PE risk cohort.
Yeah.
And for the what's the prophylactic antithrombotics that you're using in hospital? And if people are thrombosizing in the community for other risk factors, is that likely to probably almost definitely negate PE in this situation?
Yeah. So this is probably the most scary thing in the hospital. So the very first COVID patient, so we'd had lots of discussions as a group of respiratory consultants. We were not going to do CT pulmonary angiograms because some of the studies from China suggest that the contrast you give make renal impairment more likely. The very first patient I saw, completely fit, well man, athlete, sitting up in bed, pink cheeks, really tachypneic, and he gave a history of 3 or 4 days of dull bilateral chest pain and a couple of episodes of pleuritic chest pain. And I really tried to pin him down, but his history didn't sound like a classic PE, but I just thought, I'm just not brave enough. And the very first patient I saw, I did a CT pulmonary angiogram, massive, big bilateral pulmonary emboli, lots of peripheral pulmonary emboli, and had I missed that, he would have died.
Yeah.
And he had not a single risk factor. He was a skinny mini non-smoking athlete, and that was on admission that I found that. So what was key about him is his chest x-ray wasn't that bad, but that's not going to be helpful for you. So I would say that anyone who's ill, always think about PE. There is no evidence-based advice for how we should be looking after these people. King's College has released an algorithm based on body weight and D-dimer. We've decided not to follow that in quite the same way in Bristol. So we're giving prophylactic Plexane enoxaparin to everybody at the usual dose, 40 milligrams. And if we are clinically suspicious of pulmonary embolism, we're either checking for it or we're putting people on therapeutic anticoagulation. What we don't know yet is what we're going to send them out to the hospital on, but in all probability it'll be a DOAC, so Pixaban, Rivaroxaban for 3 months. And if someone is already on a DOAC in the community and they're taking it, they are unlikely to have clots.
Yeah. Yeah, that's really helpful. And it's that differential diagnosis versus probability, and making sort of pragmatic recommendations around. And obviously, if the risk factors are skewed, that's a good example of saying that you can never rule anything out.
Yeah,
but that actually we can't. There's no definite rule, and n equals 1 might be the situation.
Correct. And I think probably one thing. Well, my assumption would be, now none of this is evidence-based, my assumption would be that the people we're seeing with the scary things, so the people we're seeing with the microthrombotic cardiac myocardial infarction, the people we're seeing with PEs, they're in that second phase of the disease where the immune system's basically going mad and triggering this massive inflammatory response. So if you're seeing PE in someone with milder disease, it's probably a PE that's caused by something else and not COVID. So the COVID-related thromboembolism seems to be in the people who look sick.
Yeah, and that's another learning point, really, isn't it? That despite viral COPD, which seems to have been cut out by the fact we've all hidden our houses, all the things happen. People can have a stroke, they can have an MI, and being mindful that also in that frail elderly cohort, that there are a lot, the differentials that were already on the table are still on the table, and that we think about best care for those differentials.
Absolutely, and I had this exact discussion with the medical director of Bristol when they were pulling together the community guidelines. So in London, talking to colleagues there, they've got COVID on its own, but they're seeing almost none of the differentials on their own. They're seeing their differentials with COVID. So people are still presenting with lung cancer, still presenting with myocardial infarctions, still presenting with bacterial pneumonia, but they've also got COVID as an added extra. So this is one of these very rare situations in medicine where there may be two diagnoses at the same time. So as you say, in Bristol at the moment, you can still have COVID, you can still have the ordinary stuff we're used to looking at, but you can also have both. So don't rule out anything else, and it be a real danger for us all to think it's all COVID at the moment, because in fact I was on the MAU last week and I was sent to see 6 COVID patients, of whom only 2 had COVID. The other 4 were ill, but with something else.
Yeah, so it's keeping our differentials. That's really helpful. Has anyone else got a question that they wanted to put through, or would it be helpful to think about weaning speed and weaning rates from oxygen in COVID?
Yeah,
that might be the other sort of topic that's worth talking about do we think that people are going to come quite off if they were discharged with a quick trajectory, or actually we don't know, or we might be looking at quite a long lag time, and that's where active therapy and exercise therapy might improve their endpoint?
Yeah, so my assumption is that anyone who's discharged into the community on oxygen is probably going to have a relatively slow wean, because we're actively weaning people before discharge. So when we were talking about sending a lot of patients out into the community on oxygen, we thought the hospital would be overwhelmed. So I did hear this morning we've discharged 200 patients with COVID from North Bristol Trust. People have gone in sick, who've gone home better. And my understanding at the moment is we're not sending lots of them out on oxygen, so we are recovering them. Now, the people who are going to be a very long wean are the ITU step downs, and my experience of ARDS in the past is they can be on oxygen for 6 months. And the protocol that's going to the clinical cabinet tomorrow, written by the whole team at Serona, basically has a COVID weaning protocol whereby patients will be issued with an oximeter at home, and you'll basically keep them on oxygen, in contact with them by telephone until their SATs are over 94%.
Yeah, and that really is a very individualistic process, depending on the length of time vented, their pre-existing status, their comorbidities, and we need to treat everybody as at the speed and the rate they need at that time.
Yeah, I totally agree.
Brilliant, that's really helpful. Has anyone else got a question they want to sort of jump in with? And I think we know, as you can see, there's not always the answer to everything, but there's also no such thing as a silly question, because we're all, if there's something that's concerning you, or some particular...
Hi, Claire and Dr. Garrett, it's SJ. We might be coming on to it, but are we talking about COPD and COVID and asthma and COVID? Is that the next session?
Well, it's not a session as such. Shall I go through some of those questions?
Just to check,
and you can see what everyone's asked. And then if I'm missing anything else, we can talk about anything you like. All right? So I'm going to share my screen again. I hope. There we are. So hopefully things like safety netting, recognising the deteriorating COVID patient, things like that have been covered by what I've already spoken about. I'm just running my eye down the list here. Why do I think some people are getting severe symptoms and some very mild? So we really don't know. So it may be that there are genetic differences that explain some of it. So it's thought that the virus enters the cell via the ACE2 receptor, and that's why there was a little bit of a scare about ACE inhibitors right at the beginning. Now, we've been told not to worry about that at the moment. Patients are on an ACE inhibitor, they should stay on it. But we do know that different populations, in particular the Afro-Caribbean population, have a high level of polymorphisms in the ACE receptor. So sometimes ACE inhibitors don't work as well as antihypertensives in people of certain ethnicities. And one of the things that's been observed that I've spoken to some of my BME colleagues about is the disease does seem to be hitting the BME community harder. And certainly the same thing is there in the States. And in fact, an intervention is being worked up at the CCG to involve the BME community, and talking to my colleagues, there is always the possibility of there being genetic differences, but the other things to be raised are big families living in one property and multi-generational families possibly playing a part in some groups. But more than anything else, I've been thinking of COVID a little bit like Russian roulette. We know we're probably all going to get it, but we don't really know how badly we're going to get it. And anything I thought I knew a month ago has been wrong. And I'm seeing people like me, mid-50s, bit overweight, but no other comorbidities, getting very poorly, but thankfully usually getting better. Do we know for sure how long a person is infectious when they have COVID? No. So again, what we thought we knew, we're realizing we don't know. So we think that the virus can last for up to a week on some surfaces, particularly things like stainless steel, think door handles. And we recognise, for instance, on the first cruise ship, the one that docked in Japan, they've tested the entire boat now, and probably about 18 to 20% of people had asymptomatic infection. What we don't know is how infectious those asymptomatic people are. So the safest thing at the moment is to assume that if someone's ill, they have COVID, and that you protect yourselves with the appropriate PPE, unless you know that they don't have it. Is there likely to be permanent scarring in the lungs following severe COVID? So absolutely possibly. So some of the people in China who had cardiac complications are developing cardiomyopathy, and the natural history of some patients with ARDS is lung fibrosis, so we just don't know. What kind of flow rates do you expect patients to be on when they leave hospital? So we won't discharge people on something that you can't manage in the community. And my guess is most people will be in the 4 to 6 litre range, if that's something we have to start doing. I was very pleased to be asked the question about nebulizers. Will patients require nebulizers on discharge? So the answer to that is, generally speaking, no. Obviously, salbutamol is only helpful in relaxing smooth muscle of people with bronchospasm in things like asthma and in sometimes with COPD. Patients with COVID just aren't getting wheezy. And one of the key things, actually, which I'll come on to on the next thing, is COVID isn't affecting asthma in the way we would expect it to. And I'll talk about that in a moment. Are there any other drug treatments? So the only evidence-based treatment at the moment is paracetamol. Nothing else has been proven to work, but there are loads of things being tested. So the things I've already mentioned, remdesivir is a drug developed by Gilead in the States, which seems to have activity against MERS. and there are big clinical trials going on looking at that in COVID. We're also using nebulized beta interferon, which will help to promote an immune response against the virus. But there's new things coming through all the time. But it's sort of reassuring to know that if you're keeping someone in the community with suspected COVID because they're well enough, you are not depriving them of any treatment because there isn't any other than supportive symptomatic care. And I think that's really important for people to know when you're reassuring yourself. Hot clinic. So the NBT hot clinic has stopped. UHB has 2 hot clinic slots a day. The referral criteria are the same as before, but they're perhaps being more strictly applied. We're trying not to have people go near the hospital. There are 2 chest physicians in ED and MAU at the moment from 8 in the morning until midnight, and with the possibility of being overnight, so Friday, Saturday, Sunday night, I'm looking forward to this week. So there will always be a chest opinion at the front door, and we are discharging people if we possibly can. Asthma is not behaving at all the way we thought it would with COVID. Usually viral infections trigger quite prolonged and difficult to treat exacerbations of asthma. COVID does not seem to. So the infection rate, the hospitalization rate and the death rate are all lower in asthmatics than expected. And we're suggesting that people on injectable biologics shield. And the most recent iteration of advice, which was only posted, I think, 2 days ago on the Asthma UK website, but I don't think it will change again, is the only other asthmatics at high risk are people on combination therapy, so an inhaled steroid plus another drug, so either a long-acting beta agonist or tiotropium or montelukast, and regular use or continuous use of oral prednisolone. So you need to have asthma beyond BTS step 3, 4 or 5 and be using regular steroids for you to be shielding with asthma. But actually, even in that group, asthma doesn't seem to be as big an issue as we were worried it might be right at the beginning. In terms of treating COPD and asthma exacerbations, treat them exactly as you would at the moment. There shouldn't be any difference at all. Same antibiotic regime, same steroid regime. We don't know that steroids are harmful. One of the treatment trials actually has patients on low-dose steroid. It may blunt this cytokine storm that seems to make people more poorly. And we're worried increasingly that the information that came out of China has been edited for political reasons, so we don't really know what to believe. But there was a report about 6 weeks ago of 30 post-transplant patients who got COVID, all of whom survived. It is possible that the medications that people take for to prevent transplant rejection might actually be protective. We just don't know at the moment, but things that we thought we ought to be scared about, we've not been. And then I'm just going to show the last slide. So this is quite a long case study, and I think it raises a number of points, some of which I've covered. And I don't know which of the clinicians online posted this, but I actually think I agree more with them necessarily than the advice that they were given. So as far as possible, we're trying to keep people away from hospital. We're trying to avoid bringing people up to do blood tests and what have you. This is a case of a patient who is known to be culturing Pseudomonas, who's had a couple of courses of antibiotics in the last 4 weeks, but they're at home, still feeling a bit breathless, still feeling a bit chesty. Now, we get an awful lot of them in the hot clinic, and most of them, when we check, they've got a normal chest x-ray and normal bloods. So it's worth remembering that you can have a post-infectious cough that lasts up to 3 months. And even in people with COPD who are going to make full recovery, 1 in 10 of them still haven't fully recovered at 10 months. So I think often we need to adjust patients' expectations that if you had green spit and you've had antibiotics and the green spit have gone away, having more antibiotics isn't going to help you recover from the cough and feeling a bit chesty. Now, there was a discussion with the GP, apparently, and then a discussion with a colleague in secondary care who suggested that the patient come up for a chest x-ray. Now, it looks as though that was advice that was given pretty strongly. That's not necessary. I wouldn't necessarily have been as dogmatic there. So the guidance is that if you've had a non-resolving cough for more than 3 weeks and the normal course of events, you should have a chest x-ray. Normally, we don't do enough chest x-rays. But if someone's had a clear chest infection and they've got much better, but they're still not completely better, I would probably hold off doing a chest x-ray at the moment. Now, if added to that, the patient was shielding or they were very worried about going up to the hospital, I'm just having a frank conversation with the patient, saying, you know, you'll probably be all right if we don't do a chest x-ray. We might miss a pleural effusion, we might miss a small lung cancer. And if the patient's prepared to take that risk, I just document that in the notes. In this case, if the patient was febrile and if the patient was coughing up mucky spit, and if they were known to have had Pseudomonas in the past, I would have been happy giving the 2 weeks of levofloxacin suggested without doing a chest x-ray under the current circumstances. And I would probably be avoiding doing sputum microbiology at the moment, unless it's in exceptional circumstances and on the advice of a microbiologist. So that's everything I've got in my slide deck. I hope I've answered some of your questions, and I would suggest now that I take my screen back and people can come back on videos, turn their microphones on and just ask any other questions you've got in the last sort of 10 or 15 minutes. So I'm feeling very silly and alone here, so hopefully some of you are still there. Hooray! Hi there. So I hope that was helpful. Was that scary or reassuring?
Really reassuring. I think it's, well, in the context of reassuring when we're all making up as best we can as one big team, I think it is really reassuring. And I think it's just the fact that I think we need to view it as an evolving situation, and where we need to stay in touch with our primary care colleagues and our secondary care colleagues, and also we need to don't get too blindsided by COVID being the only problem that's ever presented in the community, and be mindful that the person will need support and reassurance due to their anxiety, and understandably the fact that how significant our anxiety is at the moment, but also recommend that make sure we're giving best recommendations around other cases and other concerns they might have, and think of the whole person like we always have done, as opposed to just worrying about one potential disease.
Yeah, so I think the scariest thing for me is the Office for National Statistics for last month, so for March. Normally in March we would have about 10,000 deaths in the UK. We had 16,000 last month, and only 3,000 of them had confirmed COVID. And we're not seeing all the things that we would normally see. There's been a 70% reduction in referrals for lung cancer. We're seeing very few exacerbations of asthma, very few straightforward exacerbations of COPD. And I think people are just really scared to come up to the hospital. And so actually it may be interesting for you to know that there is only one route into the hospital. You come through a door in ED and you're met by a nurse who triages you into the COVID stream or the non-COVID stream. and then the two streams have been kept completely apart. So if one of your patients comes up with something other than COVID, they won't be seen by doctors who are looking after COVID, and they won't be seen in an area with other patients who are suspected of having COVID. So we're being really careful, and that's something just to reassure people about.
Okay, that's great. That's it's good to that, and that's obviously a change from different systems that were published.
Yeah, totally. Before it used to be everyone would pile in through the front door and we'd sort them out afterwards.
Yeah, yeah. It doesn't feel like there's a rush of clinical questions coming your way. I think there's a rush of gratitude, but not a rush of questions. I think brilliant.
I think from my perspective, I think there's no questions because most of mine have been answered. It's not as if.
Yeah, no.
Does that make sense?
Yeah. So Sarah's got a question and Emily's got a question, I think. Did you have other questions, Sarah? No, you've turned your mic off. Emily.
No. It's no. It was in answer to kind of treating COPD and the normal processes, and you answered it in with regards to the case study. No, as far as I'm concerned, that's great. Thank you. Yeah.
So I don't know who sent me through that case study, but I think I would probably have erred to you. Yeah,
it was me.
It was a good case study. Pretty common situation, and actually an example of why community practice is hard. It's dead easy for me. I've got a nurse who'll do a blood pressure and a radiographer who'll do a chest x-ray, and then I sit down and can be all fancy pants about it. But actually you're seeing someone in their living room or over the phone. And I can tell you, I've been doing telephone consultations for the last 3 weeks. They're really hard. I hate it because I hadn't realised how much I got from patients' body language and from the way they looked. And also, I'm going to have to revise the way I practice because I think I probably provide quite a lot of reassurance from my own body language. So it's tough.
Yeah, and in that scenario, it was over the phone, but that's only to ask me if he should go for an x-ray because the GP had already told him to. And I was a bit like, whoa, I'm in kind of a rock and a hard place here. So then you had to kind of go back to the beginning and then pull it all the way back through, if that makes sense.
So if the person was ill and deteriorating, I can see the value of a chest x-ray. And as I mentioned, 3 weeks of non-resolving cough, you'd be wanting to do a chest x-ray, but you've got a patient who's going, no, I don't want to leave the house. And I think the thing there is to individualize your management plan with the patient and document clearly in the notes if you decide not to go ahead with a chest x-ray. So I've got a patient with severe asthma who is on benralizumab, which is one of the injected drugs, and she's refusing to come out to the house to go to caution to have the injection or even to be taught how to give it herself. So I've rung the GP and I hope that we're going to be able to deliver the drug to the general practice. And the patient knows it's illogical for them to be happy going to the GP surgery but not happy going to caution. I think the risk will be the same, but they've got a past history of mental illness and of anxiety. And I've said that as a reasonable adjustment, I would like the patient to stay on their benralizumab, but let's try and do something a little bit different. The GP was all for it. So Emily, you had a question.
Yeah, and it might be an impossible one, but obviously we were all expecting higher populations of COVID patients and spikes, etc. That, as you say, fortunately we've not seen. But there is still the prediction, am I right, in that mid-May to mid-June may be our sort of busier area?
So I've seen so many versions that it was going to be mid-April. It hasn't been. It was going to be mid-May. Now in Bristol, they're talking about mid-June. I think basically we were quite lucky here in that we didn't have wide community transmission before lockdown. So rather than flattening the curve, we've obliterated it. And, almost as soon as social isolation came in, we saw a big drop off in the number of cases we saw. And I think we've got about 100. So I say we've got about 100 people in the hospital with COVID. We've got 30 in intensive care and we've discharged 200 with COVID. So That's about 300 odd patients probably we've seen. We're seeing several every day. I would anticipate that what will happen is, as lockdown comes off, we might see a peak here that isn't seen in places like London. How big that peak is will depend on whether people go back to having a normal life, and I suspect most people won't. I suspect there'll be a kind of social isolation light will continue for a while, and we don't know how many people have had asymptomatic infection. Now, Gloucester and Cheltenham are being hammered, and I live in Gwent, just over the bridge, which is where I'm talking to you from now, and they've been absolutely hammered in Gwent. Nobody knows why. I think the Cheltenham Festival did for Cheltenham and Gloucester, though. That was their spring bake at Fort Lauderdale. That was an interesting video, wasn't it? Wasn't it scary that one beach load of people distributed over the whole of the eastern, northeastern United States within a week? Any other questions?
Thank you.
No. Well, really nice to see you all, and thank you very much for dialing in. I'm happy to do this again. Just let me know. Okay.
Yes. Thank you. Thank you so much.
My pleasure. Take care, everybody, and stay safe.